Welcome to our final session of Rhythm Interventions Online 2025, Day 1. The focus is SICD implantation, what and why every EP needs to know. And for this, we are delighted to welcome case presenter Michael Lloyd from Emory University Hospital in Midtown Atlanta. And we also welcome our panel, Sunil Kapur from Boston and Marco Perez from Stanford. Go ahead, Michael. Stage is yours.
And I'm happy to be here and wrap this up. I was watching yesterday and saw a lot of great content. Hopefully this is going to be review and highlight some things that was talked about in some of the earlier sessions. I think when it comes to the SICD implant, before the patient gets on the table, we need to spend a second on screening. And I've tried in the past, because this is such a promising device, an important device, especially for some of my young folks, to bend the rules a little bit on screening. But I've learned the hard way that if the patient does not pass a single vector in supine and upright position, they are at gravely increased chance of inappropriate therapy. I think it's important to remember we were all really optimistic about this idea published by Devi in Heart Rhythm, where they sort of altered the screening vector to see, based on the patient's cardiac situs, if we could kind of bend the rules a little bit. But this was a negative trial. There was a high incidence of inappropriate therapy. So we prefer two vectors in our facility, but at least one has to happen. Screening can be a challenge for my out-of-staters and out-of-towners, and something we're playing with that's in press in Heart Rhythm now is this cardia idea. Dr. Badia's really brilliant idea of using the cardia to kind of screen for the screen before the patient gets into your facility and gets told, well, you may not pass. So this is really a cool idea of looking at and taking this screening possibly in the home. So stay tuned for that. I was dismayed to find out a couple of days ago that I've tweaked my practice a lot for the SICD. And I have a beautiful recording that is not allowed to be played because it's it's involved in the IDE trial. And so instead, the good news is we're going to play Monday Morning Quarterback, and Dr. Gottlieb is going to be our shall we say victim. But it's actually probably better to comment on someone else's, because you see different styles and different approaches, and I'm sure our panel has different styles and different approaches to this implant. The point to the video, though, is that this is purely surgical, purely a surgical thing, and the learning curve all comes from the surgery. If we could play that video. Okay. So this video is really going to focus on the implant. But before even the implant starts, let's talk about some important tools that are key that I've learned really work. Now, we used to use a cardiac surgery drape for the for this procedure, and ended up getting into messes with adhesives and the double adhesive sticking to the IABAN. The very inexpensive universal drape, which is 4x4 quadrants, is the way to go. Keeping the field quite wide and rolling the patient either by a rolled towel or blood pressure cuff, which I saw yesterday, which I thought was a very good trick to inflate and roll that patient on the side to get the posterior approach and get that pocket intramuscular. The other tool to its right is the medium to large Richardsons. These retractors don't come in our pans, but they're actually about the width of the pocket you want to make for the SICD. This tool helps get in front of that belly of the latissimus dorsi and has been very instrumental in helping us dissect and get into the right fascial planes. And let's look. He's already made his dissection here, and he's going fast there. So this is something we've banned in our EP labs, those Kerlix sponges, because there are cases of, and in this specific implant, the SICD, of sponges being retained. So we don't use the small 4x4s, we use the large lap sponges. He's showing this intramuscular approach where the latissimus is on the right side of that scope. He's just showing that for the audience, and the serratus is on the anterior side. This is the so-called bloodless approach. I don't know if I can say they're truly bloodless. There are a lot of lateral cutaneous neurovascular bundles that you can get into as long as you recognize them. And that's actually a good sign to me that I'm in between the plane. You can get you can clamp them off and avoid bleeding. The paraxiphoid pocket here is as important as that big lateral pocket. Now he's already tunneling. This seems to be going in fast motion. He's already tunneled and peeled away. I pre-throw my ethibond ties in the paraxiphoid pocket beforehand, and I put little snips on them to localize it. Another difference between this implanter and what I've changed is I'm not wearing lead. I do not fluoro. And I do not fluoro because I mark up the patient. I consent the patient. When I consent him, I tell him, you're going to possibly have some markings on you. But I think as long as you have marked landmarks, this can be a fluoroless procedure. Another difference is if you have the luxury of an EP fellow, that can be a luxury or it can be a curse sometimes in July, or you have the luxury of a good scrub tech or a PA that works with you and helps with closure. I frequently am on the other side of the table working on the paraxiphoid pocket while the fellow or the APP is working on the lateral pocket. This is for pocket creation. This can also help in tunneling, but also for closure, so that two people are closing at once, keeping this down to possibly 30 minutes with about 5 to 10 minutes of good prep time. We rinse the pocket heavily. He's introduced the device inside. He doesn't use anchoring. I also don't use anchoring suture. And now he's ready for the all-important closure. Now, for me, closure is like a coeliotomy. I want this thing to be robust. He's using smaller radius needle and a small gauge absorbable suture for the muscular closure, trying to approximate the serratus to the latissimus dorsi. I have found a much faster approach is a large radius needle with Ovicryl and locking mattress to run that. We usually run 2 layers of that and perhaps a 2O for the skin and then overlying glue. And that has helped keep the pocket closed, and I think secure the device without the need for anchoring. the superficial skin closure here, he's using this zipper thing. It's pretty nifty, locket sort of device. We in our labs we use glue um, to allow them to take showers right away. For my female patients, the direction of that incision is important. Following Langer's lines, following the creases are critical. Um, I think Devi can sympathize with me. In Georgia, we have a lot of people with extreme truncal obesity in the South, and this sort of apple habitus is really challenging. And sometimes that lateral pocket is about 6 inches deep sometimes. So that's why these big tools with big radius needles is really important. So positioning, I spend way more time on positioning than any other case because getting the arm out of the way and keeping a wide field is critical. And closure, I think, is perhaps the most important. Um, I'll mention about testing and what we do in our lab. This is also part of the procedure, and the testing approach for us is primary prevention, shock impedance less than 80. We will not routinely test unless there's other clinical factors that make it really important. Secondary prevention is almost always a test. And then anything else is probably going to be a test. And of course, if the patient's not hemodynamically doing great, it's, we have exceptions to that rule. But I think testing, what I've learned by having to routinely test for the IDE in Power is there are things that come up that would not have been discovered. And I think it's important to consider testing in these patients. Now, we have the luxury of using anesthesia for our cases, but this also can be, this can be a challenge when you're only using thoracic anesthesia and some light sedation. But it is an important aspect of this procedure and should be done postoperatively in a follow-up, in my opinion. Let's briefly touch on a few slides of what's down the pike for SICD. Next slide. I can do that. These were just presented. These are the components of an MCRM system. So the SICD now will not have to be limited by its inability to pace. There's a transcatheter pacemaker that's put in through the leg, similar to other technologies that can then communicate with the SICD and deliver ATP therapy. This is done by a low energy, non-battery tax, low battery tax consuming communication process. The results are in circ A&E, good safety, reasonable overall system complications related mostly to SICD and not the Empower. So there's our implant, some tidbits pre and post. I think that the reason why we're all talking about this and why this has been featured in this RIO Congress is that all patients with indications for primary and secondary prevention without bradypacing indication should be considered. The transvenous leads are destined to fail, and I would vehemently debate anybody that says less than 1 in 10 patients at 10 years doesn't have a problem with a transvenous lead. I also want to emphasize that SICD complication avoidance is dependent on simple steps. The details will kill you, and I've been burned by this. Spend more time on the prep than your other implants and certainly the ablations, and that will make the surgery easier. And finally, the newer technology, this modular ATP system, may expand the functionality and the patient population for SICD so that you can temporarily Brady pace and deliver ATP. So with that, I want to make a plea for the to our panel of tell me what you do and what you don't do and what you disagree with.
Great discussion, Michael. Just starting with the screening, I wonder if so we use a lot of exercise screening. So we'll put patients
Yeah.
on a bicycle and then do the screening and make sure they pass during exercise, especially in younger patients who are very active and those who have, say, conditions like HCM or other cardiomyopathies. Is that something that you ever do or have done in the past?
We do. I mean, I deal with a lot of congenital, and I think that these what you mentioned, the young, is really where I will do that. I don't do it routinely, but in somebody that's young, I think it's an important part of screening because SICD has limitations, and one of its biggest ones remains to be the sensing and double counting. So we routinely enable smart pass. That's an important aspect of practice for us. That 9 hertz high pass filter that gets rid of the low frequency T wave stuff that is usually the problem for the younger people with exercise. But yeah, I think you're right, Marco.
One other point that
Are you all?
Michael, can I? Go ahead. Go ahead, Kapur.
one other point that I was going to make with
Go ahead,
regards
Sunil.
to the implant that I think is notable and was certainly mentioned is kind of the critical nature of that parasternal tunneling. I think with regards to sensing, as you mentioned, a millimeter to the left or the millimeter to the right can sometimes make a big difference with regards to sensing. And specifically, if screening was kind of borderline, that really does make a difference. And then I think, as we're all aware, even having one or two more adipocytes below your sternal wire, if you have not a kind of really scraping the sternum, it can really increase your shock impedance and reduce your ability to defibrillate. So that, I think, from a procedural perspective, is something to spend some time on and certainly be very cautious of. It's a little bit counter to our nature of being delicate during our ablations and being very gentle, the real kind of scraping of the sternum. But I think that's probably a critical portion where, if we're thinking of places where we've been burned before, that I think warrants a kind of a thinking about a little bit. I know Marco has taught me over the years a couple of different techniques to really make sure you are going in those deep planes, maybe even using some adjunctive imaging, ultrasound, but there's different techniques, but really an important part of the procedure.
Critical
Yeah,
point
I'll
that
definitely echo that because I think one important factor to remember is that the more fat you have between the electrode and the can, the higher your impedances will be and the higher likelihood of failed DFT. So really minimizing, and that's why we use the intramuscular technique because you minimize that all of that the fat along the chest wall, and then as Sunil was saying, we've been using a lot of intraoperative ultrasound to make sure that our probe is as close to the level of the sternum as possible. And we've done now a pretty moderately large series of patients and have found that by using ultrasound, we've decreased our impedances significantly. So hopefully we'll be able to publish that in the next few months.
Michael,
that's an
your
important
question
point.
on screening.
Go ahead.
Go ahead. Finish
I
your
just
thought.
wanted,
Okay.
I feel obligated to comment on Sunil's point that it's critical when we're doing the paraxiphoid pocket to get. I actually kind of dissect a little bit, almost near the periosteum of that presternal fascia, and I tell our trainees this needs to be you feeling that bone, and my angle of approach is super deep. That's probably the most important, in addition to this that the posterior location of the generator. Thank you, Sunil.
Yeah, I was gonna actually say we had a surgeon yesterday walking us through proper closure techniques for SICD and Droghetti, and it will be available on demand. But I thought it was phenomenal, just learning basic suturing skills, and like you said, Michael, a lot of this is just basic surgical skills and preventing infection. I have a quick question about screening. How strict are you with screening? Like, if you have a patient that say barely fails one vector, are you okay? Are you okay with that? How do you handle screening? And I'm looking forward to seeing this whole cardia thing. Seems so cool.
I agonize a lot about a patient that barely makes it in one vector. Um, Now, there are some patients where there's really no other option. You have a tetralogy patient with VT, prior a secondary prevention thing, and bilateral occlusions from all the prior transvenous stuff they've had. And I might push it there, but I really would be nervous about that case.
Yeah, I think I'm very similar. I will require at least one vector passes, but and I pretty routinely do the exercise. In the lying, sitting and standing positions and exercise, they have to pass in at least one vector because as Michael was saying, the issues that you run into, the one of the biggest issues is it's a little bit hard to predict preoperatively is that when you have relatively small R waves, you tend to smart pass filtering tends to be turned off if that's the case, and when that happens, small R waves with smart pass filtering turned off, you have a greater likelihood of detecting just inappropriate shocks and detecting myopotentials and so on. So I'm in that sense, I'm also pretty strict about that.
So, no,
May I
can
say
you
something
give us some
about that?
tips? Yeah, go ahead.
I need to mention the smart pass. It is an important feature of the device. And what Marco mentioned is critical. You can turn it on and SmartPass will auto disable. So if there are, I forget the criteria for how many low R waves it needs to see, but it'll turn itself off and it'll send an alert saying, hey, something has changed to the device clinic, but you can turn it on and it'll turn itself off if those R waves are small or if it sees asystole or some other things.
So now let me ask you a question on, can you give us some tips on preventing lead migration, especially in athletes and pediatric patients?
Yeah, no, it's a really important point because I think certainly we always worry about lead dislodgement with our transvenous, but certainly it can be happen here as well. I think probably the biggest key is tying down to real fascial or muscle tissue, specifically for the bigger patients, and we get some of them up here in the north as well. It is a little bit hard to dissect down to that actual fascial or periosteal layer. I think if you're able to tie, and we do a similar technique of doing some pre-ties, doing 2 or 3 pre-ties, and then after tunneling the lead, actually latching those on to the anchoring sleeve, but making sure that those are actually against some solid fascial tissue really helps prevent lead migration. We've moved away, as I would think a lot of folks have, from the 3 incision technique. I could probably think of one case in the last 5 years where I've used that. So I don't think that's necessary to prevent lead migration, but I think those fascial ties are important. And then I think going back to the point of parasternal tunneling, if you're in that really right above the sternum plane, I think there is some degree of that tissue holding the lead in place that works for your benefit. And so, again, another reason, in addition to shock impedance, in addition to sensing, to really make sure you're in that plane, because I think that kind of hugs the lead to the sternum and prevents lead migration again.
Yeah,
Let me ask
I
you a
will.
question about ARVC
Yeah.
patients, because it has come up in our practice, and we're starting to see more of these patients. Are these patients at higher risk of oversensing or therapy failure due to electrogram instability?
Yeah, the issue with ARVC and HCM, the issues there are that, well, one with the HCM patients, they tend to have really large R waves, and so they may end up failing because the R waves are too large. But the bigger issue, I think, is with, and this applies to both ARVC and HCM, is that they do tend to have a higher rate of rate induced QRS and T wave morphology changes. And so that's when you start running into the issues of T wave oversensing, double counting, as Michael was alluding to. So that is one of the main reasons I do treadmill them, is because I want to look for any rate related changes.
Michael, before we close the session, I'm going to give the floor back to you to give us your final thoughts on where you see the future of the system is. Will it be the default system?
think-
Are we heading that direction, or
Yeah.
is there more to be done?
Absolutely. The transvenous lead for defibrillators specifically, pacemakers not so much, but defibrillators specifically is going to go away. And I think there's a lot of new technology. This system, the modular, other systems are going to be the way to go to protect someone from sudden death without having stuff in their heart.
We have run out of time for this session. It's been a great 30 minutes of understanding SICD, and our thanks to Michael for bringing us a case and giving us some Monday morning quarterbacking. And thank you, Sunil and Marco, for their excellent contributions. Stay with us as we reflect on this day. Thank you.